This morning we've got Dr. Mohamed, one of our pediatric urologists. Dr. Mohamed completed his pediatric urology training at Nationwide Children's Hospital in Columbus, Ohio, after completing his medical school, his Ph.D. in urology residency at Cairo University in Egypt. Dr. Mohamed's areas of interest include reconstructive surgery for various congenital anomalies, as well as the management of obstructive uropathy, voiding dysfunction, stone disease, and urological tumors in children and adolescents. Dr. Mohamed is certified by the Egyptian Board of Urology. He is a reviewer for the Journal of Urology and a member of several professional and scientific societies. Dr. Mohamed has published numerous articles in the field of pediatric urology, and today he's going to be talking to us a little bit about vesico-ureteral reflux. Dr. Mohamed?
Thank you. Good morning, everybody. Thank you very, very much for the kind invitation to join your Friday meetings. I hope I won't bore you much with the PP talk. We're going to be talking today about where we are in the management of vesicoureteric reflux. This was not actually the initial title I submitted when we were asked to give this talk. Looked at it yesterday. It was how to navigate different guidelines for management of vesicoureteric reflux and other diseases, updates from the world of care. I thought it was too long, especially when I saw next week's talk, Room with a View. I felt really embarrassed. Sounded like a movie. Then I realized maybe I stopped beating myself. It may sound like a movie, but maybe I have just a dark black and white movie taste. So I have no financial disclosures. We're going to be starting just a quick introduction. Remind everybody, no offense, residents. What's reflux? So the way I tell the story in 2 minutes for the parents, you have two kidneys, sometimes one. Kidneys take the blood, they work 24/7, filter the urine, filter the blood, make urine, excrete waste products, take back the good stuff like glucose. End result, they make urine into the collecting system here, goes down the ureter. At the junction between the ureter and the bladder, which is the uretrovesical junction, UVJ, this is supposed to act like a valve mechanism with many mechanisms involved that we'll talk about in a minute. But normally, urine goes in one direction. If when the bladder fills, urine starts to go up, that's reflux. The problem with reflux by itself is not that it exists. The problem is mainly it predisposes to infection and kidney damage. It's a pretty old disease. There are very old descriptions of the UVJ, as old as 200 AD. Da Vinci described it as a unidirectional flow, the Da Vinci, 1500 Da Vinci. We knew after that some animals have reflux, like rabbits, dogs. Then it was discovered in humans and described in literature in 1893. Nasty urologists would tell you that it was discovered by a gynecologist who severed the ureter and started seeing urine coming from the other way. But these are nasty claims. And then 1924, 1944, we started talking more about it being abnormal, that having urine go the other way is not good for you. And then they started studying more what prevents reflux and the physiology of the anti-reflux mechanism in order to understand why it happens. The length of the tunnel, which is something urologists love, the ratio between the diameter of the tunnel of the lower ureter to the submucosal tunnel, we'll show in a minute, was described in 1950s. That's the tunnel here. So the anti-reflux mechanism, one of its main components is the ureter. As it goes into the bladder, it travels through the wall for a certain distance, submucosal for a distance, and then you have the ureteric orifice inside the bladder here. So as the bladder fills, it just opposes the two walls of the ureter and prevents the reflux. The length of the tunnel has been described as one of the main predictors whether there is reflux or not. This being a short tunnel, medium, or normal length tunnel. Another mechanism would be the peristalsis in the wall of the ureter itself. They also describe that in spinal injuries or iatrogenic or experimental severing of the spinal nerve, the lumbar nerves, some cats may develop reflux. I wonder how the IACUC was then. So later, maybe 60s, 70s, we started to focus more on the relationship between reflux and infection, and how reflux by itself, as I said, will not be the issue. We know some about the epidemiology of reflux. Most of us know that it's usually a girl. Oh, sorry, before that, when do we discover reflux? Usually if we have a urinary tract infection, we get the kids tested, and you have a 1/3 chance of having positive or more. And more would be in the younger ages, infants. If we are testing kids for prenatal hydro, you have a 25% chance of finding reflux. As I said, it's more prevalent in general in females. However, in infants, especially presenting with dilatation, it's more possible that you find it in males. That may have lots of factors there. It's possible that every boy with any abnormality will have will be more aggressive with ultrasounds and VCUGs than girls. Also, if presenting with UTI later in life, they found it more and more men. There is also variation between countries where there's circumcision, there's no circumcision, especially in race. It's more in white than African American or Latinos. Oh, sorry, in whites and Latinos more than African Americans. Not all VRs are the same, so there are grades for reflux. We described 5 grades for reflux. However, this is actually the picture I used to trick our residents, because I showed them this picture, told them, oh, I have the picture, tell me what are the grades. And they start saying, well, no reflux. 1 is to the ureter, 2 is up to the collecting system, no dilatation, 3 starts to dilate and cupping of the calyces, 4 you have cupping of the calyces and some tortuosity or dilatation in the ureter, 5 you have thinning of parenchyma, and then say, you got it wrong. Because in reflux, we diagnose it by VCUG. There is no parenchyma seen. The dilatation is in the collecting system, more dilatation of calyces, more tortuosity of the ureter. But you cannot judge the parenchyma. It's when we look at the whole picture with the ultrasound, with the VCUG, that's what gets them confused. But to just describe the grade, these are the grades. And that leads us to the VCUG, the test we have to convince parents that your kids need. There are certain guidelines and ways and precautions when doing a VCUG. We do it usually to diagnose reflux, which we suspect when we have a kid with infection. So do we do it during infection? Preferably not. In very rare cases where we have recurrent negative VCUGs and persistent infection or recurrent infection, then we would be more aggressive and do 1 during or close to the attack. Usually we wait for a week on antibiotics at least. Definitely off fever. The reason for that are 2 things. First, by definition, if you're going to inject the contrast into a bladder and see reflux into the kidney, you are taking this infected urine pushing it into the pelvic calcium system. Instead of asking the kid to void frequently or put a catheter, you are actually making sure that you can see it going up there. The second reason is infection by itself may cause transient reflux. So by the edema, by altering the wall, the tunnel. So we don't want to be catching reflux that may otherwise not exist. The catheter. Preferably, we do it with a straight catheter, not a Foley, to avoid having the balloon change the picture there. The volume. We calculate approximately the bladder volume and not exceed that. And that's either by weight under 1 or 2 years, and by age under 2 years, and by weight after that, age plus 2 times 30. No pressure. It's supposed to be hanging a meter above the kid and just flowing into the bladder. We take several pictures. Take the early picture to see when the bladder is empty, if there is any filling defects, uretroseal. We take when the bladder is full. We have to get the straining. It's avoiding cystourethrogram. I mean, as much as possible, as much as you can convince a kid to void. Sometimes you can't. It's because some reflux only shows when the bladder is contracting, when the pressure rises there. And then you take a delayed after you void for either you can see the lower ureter with reflux in it, and you can estimate the post-void residual urine. We also prefer doing it as cyclic, doing 2-3 cycles of fill in empty, fill in empty. However, with the new less radiation requirements, with the LRO as low as required use of radiation, if we have good enough pictures, our friends in radiology may stop the test, and we agree with that if we have results. 2005, 2008, there were talk about the positional installation of contrast cystogram, or the PIC cystogram. If you may come across it, if you talk about reflux. Basically, it's a cystoscopy. They go with the scope inside the bladder, look at the UO, and then use contrast instead of the irrigation fluid. So we're like pointing a fire hose at the ureter and saying, can you reflux? Do your flux. And then they used to treat it according to that. I don't think it's right. Alternative to the VCUG, we can use, instead of contrast, the radionuclide. It's one of the technetium isotopes. I don't think it's very popular in this institution. Probably seen one. I did not order any, however. Not a big fan. But elsewhere, it's used frequently because theoretically it used to use about hundreds of the radiation used in a VCUG. Again, with the newer VCUGs using less radiation, the difference is not as obvious. The drawback is it only shows no reflux 1, 2, 3, and 4 and 5. So there are just 3 grades of reflux. We use it mostly to just say, is there still reflux or not? So it's not used for the initial diagnosis or follow-up, either post-op or long-term follow-up for conservative treatment. But if I'm planning an intervention, we still repeat the VCUG. What other tests? Ultrasound, of course, our beloved ultrasound, safe, economic. However, in reflux, it has limited value. It's good for detection of obvious scarring, not any scarring. We can also suspect scarring by doing serial ultrasound, seeing if the kidneys are growing symmetrically. We can use it to see, of course, hydro if there is severe reflux. But we have to keep in mind, as strong a statement as this may be, but it's completely true, there is no significant correlation between a normal sonogram and the absence of reflux. Having a normal ultrasound does not mean they have no reflux. Even grade 5, 10-15% of them have normal ultrasound. You'd be surprised. You open the kids' pictures side by side. How can this VCUG be for this ultrasound? No way. You can see dilated system. You can see dilated ureters, and the ultrasound is completely normal. Then we go to another test we do, the radioisotope renal scanning. It's a radioisotope tracer given IV, and then should go to the blood and go to both kidneys. Optimally, you would have 50%, 50%, but we have difference between our right hand and left hand. 45, 55 is fine. Up to 40, 60%, we start worrying that this kidney is affected by scarring, or its function is decreased, or its uptake is decreased significantly. That would push us to intervene. It also can show us the scarring in the DMSA. That being said, every textbook, most of the papers coming out, we all still talk about DMSA. I have not seen a DMSA in 3 years or more. And that's has nothing to do with DMSA being bad. It's still the gold standard. It's just the company that makes it does not make it anymore in the world. And nobody cares. We have to go to other alternatives which may not be as accurate with the scarring, but give us an idea about at least the differential renal function, MAC3 or DTPA. These were supposed to be the dynamic tests used to detect obstruction, because we keep taking pictures and see that tracer being excreted by the kidneys. Gives us the excretory phase, how fast that tracer is being excreted, like in UPJ obstruction or other forms of obstruction. We're all talking now about the primary flux. Primary flux is the problem, is the UVJ. There's also the secondary flux. We have to mention it because we see it very often. And we see reflux with other diseases, like associated with other renal or urinary tract anomalies. That's correlation. We're talking about having a UPJ, obstruction, up to 18% may have still reflux. Duplex kidneys, maybe that's because the UVJ the tunnel is short for the lower moiety. Even horseshoe kidney, there's no reason, if you look at it, that there would be reflux, but there is. It has to do with the way it develops. But secondary reflux, this is the primary. Secondary reflux is secondary to a problem in the bladder mostly. Either a congenital problem in the bladder or the urethra, like a posturethral valve in boys, where the bladder fills, there's high pressure, and then up to 50% would have reflux. If you treat the valve early in life, in 6 months, you have a good chance, maybe 50% of resolution of that reflux. You can have acquired, like AD. Congenital would also include the spinal cord defects, dystrophism, but you can have acquired spinal cord injury. You can have acquired denervation of the bladder because of pelvic surgery. There is also the behavioral bladder dysfunction. Sometimes we have what we call a non-neurogenic neurogenic bladder, a bladder that acts exactly like a neurogenic bladder, but Hinman syndrome, there's nothing. We cannot find any nerve defect. And behavior includes holding, includes what we'll talk about later, the function elimination. A urethral seal. utensil, if it prolapses to the bladder neck on one side, the other side may reflux. So how do we exclude or confirm secondary reflux? We have to go back to evaluation. First, again, like any disease, residents, we don't jump to imaging. We have to take history, and that tells us a lot. After 2 office visits with the mom and the kid, and after lots of half an hour interview, then she finally tells you, oh, and he had suspicion of tethered cord, and we did the surgery, and oh, did I not check the back? Oh. You miss 1 or 2, and then you stop missing them. So history, there's also constipation associated. You can check the kidney, the back, check the gait of the kid. I remember few, not one, kids where we, as urologists, discovered toe walking or send them to their pediatrician bag or to neurosurgery right away, and they had definite tethering. And assessment of the lower urinary tract. Keeping in mind that, again, primary and secondary reflux may overlap. You may have a defect in the UVJ that's being exacerbated or persistent due to a bladder issue. For evaluation, we go back to the VCUG. We check the bladder contour. Is it a normal-looking bladder? Is it corrugated? Do we have Christmas tree that we're missing? Look at the bladder neck. Does it look spindled? Maybe they have dyssynergia. Maybe the bladder, every time it contracts, the sphincter contracts. That dyssynergia. So that creates high-pressure bladder. We can do more investigations like uroflowmetry or urodynamic testing, and we can get MRI of the spine. An area of overlap, again, between primary and secondary bladder and bowel dysfunction, or what we call dysfunctional elimination. Kids who have constipation, who cannot relax to void, cannot relax to empty. And if this is missed, you can either have more complications of your observing. You can have kids that get breakthrough infection on prophylaxis or watchful waiting. And even if you do the surgery, you have a higher chance of failure. That's why our famous poop chart in the office. We have to use that. Kids love it, by the way. Breaks the ice every time. I always tell them, sorry, they're called food names sometimes, but here it is. We try to avoid the 1 and 2, of course, and the 3 sometimes. 4 is okay, 3 and 4, 5. After that, it's too much. And the way I explain to them is 1 and 2, yes, you're having a bowel movement every day, but you're still full of it. It's not enough. And we get an x-ray sometimes just to convince the mom. But he's pooping, yes. Here it is. This is what they describe, and this is, look at these white and gray shadows, that's poop still inside. How ethical that is, we always talk about it in conferences. Should we expose the kid for x-ray and just to win an argument with the mom? Yet to be discussed. Then managing, or again, we mentioned all the modalities of testing. This is an expression we discuss every 6 months, not every pediatric conference all over the world. Should we go top down or bottom up? Every year. Haven't reached this answer yet. What it means is, if reflux by itself is not the issue, um, should we look for it or should we look for the ones that count? And that was because when they followed kids with reflux, not all of them developed scarring. And they would be saying, well, you've been following up this kid with repeated ultrasound, with repeated VCUGs, with all these antibiotics, although he would have never had scarring. So they said, well, go, if you want to diagnose reflux, go ahead. If you get an infection, you get a VCUG and see if you have reflux and treat accordingly. But alternatively, if you get an infection, get the end result. Go from the top. Get a DMSA. If you don't have scarring, don't do a VCUG. Different in opinions. I'm still with the bottom up. I want to know what's going on. Getting old, I guess, as I said previously. But again, we have to remember we don't have the MSA. We have to depend on the alternatives. That's why everybody now is actually doing the bottom up. So we talked about this briefly, but we'll get back to it later. As we think the sequence of event is, the kid has reflux. Could be asymptomatic. We never know. It will resolve on its own. Nobody ever knew. Could have subtle infections. When the kid is 5, we tell the mom, well, she's got 2 infections. Let's get a VCUG. Oh, it's positive. That explains why she was having some infections for one day and we would not go to the pediatrician. Why she was having. So it was subtle infection that nobody noticed. It could have recurrent febrile infections, and that could lead to pyelonephritic scarring of the kidney and long-term consequences, hypertension, end-stage kidney disease, mild or severe, decrease in the function of the kidney. And the reason this is important is sometimes it stops here because reflux sometimes, or most of the time actually, resolves on its own. So it's possible to resolve. It's possible to persist, and it's possible to get worse, unlikely. And that's just, we're talking about reflux, not infections. Infections can also happen, either go away with management or not keep on getting breakthrough infections. Who is going to resolve? We have to tell mom. Your kid is grade 1, 2, or 3, which has a higher chance to resolve on its own. Your kid is 4 or 5, it has a lower chance to resolve on its own. Keeping in mind that if he has an 80% chance of resolving, I don't know if your kid is in the 80 or the 20. If he has grade 5 reflux, grade 4 reflux, he has a 10, 15, 20% chance of resolving. I don't know if he's in that 20 lucky guy or if he's going to be in the 80 that won't. The age, the first year better than the first 5 years, better than the next 5 years. The third parameter is something talked about later in the past 10 years, whether when we do the VCUG, put a catheter, put contrast in the bladder, do we see the reflux right away? Or do we keep filling the bladder, start voiding, and then we see the reflux? The first has a lower chance of resolving on its own than the latter. If it happens right away, that's worse prognosis. Duplex kidney, by definition, that means that there's a severe anatomical problem there. How many of them resolve? This is the best table we have so far. To summarize it, grade 1 has in this range of resolving on its own, or 1 and 2 low-grade reflux have 80% chance of resolving. 3 and 4, we talk about 50, or in 4, we talk about less. Also, they found that if you have bilateral grade 4, that's worse than unilateral grade 4. In these curves, grade 4 bilateral, it has like 5-10% chance of resolving. Unilateral has a higher chance after 3, 4, 5 years. These are prognostic factors, probabilities. Again, we use them to counsel the parents and to anticipate what's going to happen. But there's no way of telling until we watch and wait and see. So watch, wait, and see. What are we going to do about it? Our first line is non-surgical in reflux, in all of them. We call it conservative, watchful waiting, and it is not doing nothing. In fact, it includes antibiotic prophylaxis, which again is debate every year, waiting for new studies, doing new studies. Never resolved the problem, but the consensus is it's good for you. So we do antibiotic prophylaxis, daily dose mostly. We start with amoxicillin, 2 months. Do not switch to Bactrim, please, before 2 months, or nitrofurantoin. They're allergic, Caflex or some cephalosporin may work. Bactrim is what you use as default standard. Once a day, its prophylactic dose is 2 milligram per kilogram. Nitrofurantoin is not bad. It has its side effects, be it the regular kids throw up. Bactrim can cause myelosuppression. We just had a kid with a leukocyte count of 2.2 last week, and we did not know why, and then yes, we did that. So sometimes we switch antibiotics every now and then. Intermittent is something talked about recently, as in stop it every now and then, stop it for 6 months and wait and see. Give it with infections, although that's why they started the antibiotics in the first place, because they found out that in the 70s, girls who were on treat as needed started having more and more scarring and end-stage kidney disease. But even now, at the age of 5 and 6, with no breakthrough infections, we consider stopping it. And that's why we say sometimes that's completely conservative management. We're not giving anything, we're just watching. But watching is close watching, especially if we're not doing anything. We have to do serial urinalysis cultures. The interval there's no gold standard for it. 6 months, some people do 3, some people do a year. Important to tell the parents, if you have any suspicion of anything, go to your pediatrician or urgent care, get your urine tested. We do voiding cystouretogram or radionuclide. I think a year is a good interval because there's 18% chance of changing, but 6 months would be too close. Upper tract studies, ultrasound at least. Make sure, I know you guys do probably, but as urologists, I have to remind myself and everybody to take a look at that upper part of the chart where they have the vitals and the weight and the blood pressure that I never look at. And these kids, take a look at it. So between the after the antibiotic prophylaxis and before we do the just monitoring and follow-up, we have to do also certain measures. That's why it's more of an active procedure. We have to tell the kids, don't hold your pee if they're toilet trained. We have to treat any voiding dysfunction. We have to treat constipation. If they have dysfunction, we can be aggressive. If they have positive or even borderline urodynamics, we can tell them to, if they're not holding post-void residual, we can give low dose of anticholinergics. If they have dyssynergy or overactive bladder neck, alpha blockers sometimes. Rarely, but we do. Constipation, essential. Constipation by itself, without reflux, without any anatomical or functional abnormality in the urinary tract, is a risk factor for infection. That has to be treated. Biofeedback, do that in the office. We put the receptors on them and ask them to relax and contract their pelvic floor and pee and see how they're doing. And then you do the washing. So what if non-surgical doesn't work? They're getting breakthrough infection. We have evidence of scarring. We waited too long. We can consider minimally invasive procedures, which is the deflux. That's the trade name. It's a bulking material injection, submucosal intraureteric, or submucosal at least. Lots of material has been tried, but the deflux is the one that we use around here. It's pretty expensive. I mean, we get paid for a cystoscopy and an injection, but the parents come back and tell us, oh, that was $7,000 for 1 milliliter or whatever. So, however, even if it does have a low success rate, this is a kid I added recently to the talk. If BM, who presented with recurrent urinary tract infection, she was not diagnosed as reflux originally. I have to say that she had her testing when she was 4 years old. After the testing, the VCUG was positive, bilateral grade 3 reflux, 2 to 3. She got antibiotics. She still got 2 infections in 6 months, better than before, but she was referred to us. And then we thought, okay, let's try that. It has good results. It's not the best modality. Surgery has a high success rate, 95%. If this is 89, 90 in grade 2, 75 in 80, 75 to 85 in grade 3, less than 4, probably not at 5. But if I can get this in 3 months with no antibiotics, no reflux whatsoever, why not? It's a half-hour procedure, outpatient. She goes home the same day. Hurts 1 or twice when she pees. May have a few drops of blood once or twice. And if it fails, we can still do the surgery. Why not? But we have to select the patients, those who need it only. Again, some radical urologists would say, well, deflux is for those who don't need intervention in the first place. Yes, but it helps other kids who need minor intervention. And we also have the surgery. So reimplantation surgery, reimplant. Our famous surgery. Of course, if we called it ureteral cystostomy, we would not get any referrals. So we get referrals for reimplants much easier. What it is recreating the tunnel. Whether we do a submucosal tunnel from inside the bladder intravesically or from outside, subserosal tunnel, whether we reimplant it cross-trigonal, our favorite Cohen procedure, whether we do polytannulate method, the old-fashioned, give them a tunnel going up or going down. That's the basic idea behind it. It has a very high success rate. They have to stay in the hospital for a night or 2. We have to open the bladder. They get horrible irritative symptoms after that. Some anticholinergics, they should be fine. Another thing is, well, something that our colleagues in adult urology tell us, something to consider when counseling the parents. is there a stone history in the family? Because we get lots of bad feedback when an adult urologist goes in for a ureteral stone extraction, something that should take 10 minutes, and then he finds the ureter in the dome of the bladder because some pediatric urologist did that. The approach could be open, that's our usual. Laparoscopy had some role. Some trials went through the bladder, like inflate the bladder instead of inflating the abdomen. The fancy robot, we have one here. We did we did some procedures on it, mainly a couple of nephrectomies, a couple of paroplasties. But on reflux, it's not yet agreed upon. Of course, as we said, Da Vinci discovered the ureter, and then the other Da Vinci is getting paid for it. So other surgeries, if we have a duplex system, sometimes the reflux is only on the lower moiety. We can take that lower moiety, implant it in the upper moiety, ureteral anastomosis, ureteral procedure, we're done. We did not touch the bladder, much better recovery, works just fine. If that duplex kidney and we have a moiety that's refluxing, causing infections, useless, zero function by renal scan, take it out. It's not worth it. We don't do the reimplant surgery under 2 years of age. If we have a really bad reflux, life-threatening infections cannot be controlled, a vesicectomy may be a temporary answer, unfortunately. Just put an opening in the bladder, drain it to the outside, wear a bigger diaper, that's it. Again, we go back to the sequence of events. We said it could be usually recurrent infections called the scarring and long-term consequences. But, and it's a big red but, we have to remember that reflux could be, from the beginning, associated with congenital renal dysmorphism. Dysmorphism, bad morphism, bad looking kidney, icky as we call it. We don't know if that's a scarred kidney because of recurrent infection or that's the way it is, because we see it a lot in kids with no history of infection whatsoever. Let's consider this guy. Again, a 5-year-old, but this one was diagnosed with prenatal hydro. This is how it looked like in 2011. Right kidney, some hydro, left kidney, looks good. This is not hydro, by the way. These are the pyramids of a neonate. And then, when he had the hydro, they did the VCUG, had grade 4 reflux. Later on, because we don't do a MAC3 scan before 6 weeks of age. Later on, got the MAC3, the renal scan, I think that was okay, and it showed 31% function on that kidney. At this age, we did nothing. Just wait and see. He was put on antibiotics. Luckily, he had no infection whatsoever. 2012, 2013, even that hydro resolved. That was the right kidney. However, always the right kidney was like 7. This one is 8 and 9 centimeters. Reflux persisted. He came again in 2016. Ultrasound, kidney on the right, bigger kidney on the left. And we did this first. We did the scan first. And that showed some decrease in the function. It was now 26, 28%. And mom was going crazy. We did nothing for that kidney. Now it's losing more function. What can I do? It's scarred. It's small. Well, I mean, he never had an infection. Just because he has reflux and because that little decrease in function, and because you're coming every 6 months for an ultrasound or VCUG or some test, and he's now 4 or 5 years, let's do it. Let's at least, let's try defluxing. I know it's maybe grade 4, but let's first redo the VCUG. He has no reflux. He no longer has reflux. There's nothing for me to do for him. That's the way his kidney is, mom. She complained to his pediatrician, called me. There's nothing to do for him. That's the way his kidney is. I convinced her. She's happy eventually. I mean, I told her we only need 1 kidney. If we have a kidney and a half, well and good. So, the problem again with all the discussions and the controversies is the science that leads us to the guidelines. There are several landmark studies in reflux. The international study in '92, the Swedish trial in 2010, and lately the RIVER study, the prophylactic antibiotic study for Vesicoureteric reflux. The plan was to come here today and discuss all of them in details, and then realized that we spent a couple of journal clubs discussing only one of them. And I thought that would be unfair. But the baseline is this one was not so good. The RIVER study ended by saying, the way I interpret it, again, because even after they put the results, people interpret it in different ways, keep the antibiotic flowing. The one that did more controversy, however, was the AAP Guidelines. That was a big change in 2011 because they changed a fundamental practice there. However, I don't think we needed to make that big of a fuss about it. First, the guidelines were specific age group 2 to 24 months. What it says was, if you have a kid with fever and you got to start empiric antibiotic, get a culture. And if you're going to get a culture, don't put a urine bag on boys who are uncircumcised. That's nonsense. The urine collection methods, we all do the mistakes because if it is negative, it is negative. But if it is positive, we wasted, we wasted the chance to know if that's actually his infection or just his stigma infection. So a cat specimen or a suprapubic aspirate. Also, if you have, they talked about assessing the risk, whether how the fever, associated problems, all this, and get the culture. They changed the positive culture from 100,000 to 50,000. I mean, we all agree on this. The urologists did not object on these whatsoever. And they added to have a positive urine as well, either bacteria or pyuria. Oral antibiotics are effective. Well and good. The science says so, so we oblige. We don't have to admit patients, we're even better. But here's where the controversy came. They said if you have a kid with the first urinary tract infection, don't get a VCUG at this age. Either wait for a second infection, but you have to get an ultrasound. And that's what threw urologists a little bit off. They said we have several studies that show that ultrasound is not a good parameter. However, there are studies on the other side that say, well, there's no much scarring, which brings us back to top down, bottom up. There's no much scarring with the first urinary tract infection. Because in the Swedish study in the RIVER, we did the MAC3s, and you can tell. And other urologists went back and did retrospective studies, looked at all the kids who were diagnosed with reflux and how their ultrasound looked like. Well, again, you have to assess each case. If the kid was admitted to the NICU or the ICU for 4 days for infection and arrested twice, I would want to know. I would not want to wait for the second UTI. If it's just one UTI treated, maybe yes, I oblige to this. The science supports it. We both agree again that for an abnormal ultrasound or recurrent UTI, we get a VCUG. No difference there. We have to instruct the parents to get a urine tested. Yes, we agree. So, one of the things I wanted to mention today is how are we gonna be treating these kids between pediatrics, urology, nephrology, primary care, family care. I think we have to talk. It's a teamwork. Whether it's just on case-to-case basis, monthly or conferences. I missed in my fellowship, we had the nephrology, urology, radiology conference. We just sat there and talked about the ultrasounds and the VCUGs. Reflux may not need a multidisciplinary, but just in general, that's also a good way to do it. And hopefully also we get some research studies going. There is a lot to be studied there, and we have a big population. I think it's wasting effort to leave all this. Thank you. Again, thank you very much for having me today. And I'm proud of myself for resisting to make any funny political jokes. I just got to put the family at least. But any questions? Good.
Thank you.
Thank you.